Thank you. Thank you, everyone, for joining us at today's webinar on supporting health and well-being, people with intellectual disability, families and supporters. Hi, I'm Mandy Knight, and I am part of the National Centre of Excellence in Intellectual Disabilities Health Lead Group. I will be chair for today's webinar. We will begin today with an acknowledgement of country. As a member of the Learning Lead Group, we respect First Nations people and elders from this land. First Nations people have lived on this land for many years. Now we live, work and play on this land together. We can learn a lot from their stories and their knowledge. We have some important information for the webinar today. If you have any questions, please type them into the Q&A box. You will get an email after the webinar with the recording. Now we will play a video about the centre.
Hello and welcome to the National Centre of Excellence in Intellectual Disability Health.
We call it the Centre for short. This centre makes sure people with intellectual disability get better health care.
At the centre, we talk to people with intellectual disability to find out what they think is important.
We talk to families and support people.
We work with health services and disability groups.
We bring information together from across Australia.
We share information about how to make good health services for people with intellectual disability.
We make sure there is health information for people with intellectual disability, families and supporters, health and disability workers.
We speak up on the big health issues and drive positive change.
There are 9 main groups in the centre. We call this the consortium. There are also more than 50 wonderful partnering and collaborating organisations. People with intellectual disability are a big part of the centre. People with intellectual disability work at the centre.
We're excited about improving the health and well-being of people with intellectual disability. Please join us.
To find out more information, go to our website nceidh.org.au and sign up for our news.
Welcome to the centre.
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 Yay!
I would like to introduce your speakers for today's webinar. We are joined by Professor Nick Lennox, Dr. Rebecca Kelly, and Miss Brooke Canham. I will pass over to Professor Nick Lennox to get the webinar started.
Thank you, Amanda. I appreciate that. I'm going to present a short overview of the Comprehensive Health Assessment Program and why health assessments really do matter. And I want to acknowledge the traditional owners of the lands that I'm on. I'm representing from Brisbane. the lands of the Turrbal and Jagera peoples, and pay my respects to their elders past, present and emerging, and any Aboriginal or Torres Strait Islander people on this call. The important thing is the context of people's lives, and I'll just make some further acknowledgement, hopefully once I learn how to use the controls properly. Oh. So the basic facts are, and that people with intellectual disability die 27 years younger than the rest of us. This is an astounding figure, and they represent about 500,000 Australians. There is a major influence of the person's where they live, how they live, their situation in terms of the society that influences their health outcomes. And when I first started working in this area, I was struck by some research that was done in Australia, where they found on average there was 5.4 medical conditions missed or poorly managed in people with intellectual disability. And this is an astounding figure and deeply concerning. And if we look at some of these conditions from a very kind of biomedical point of view, I guess, is that there's lots of conditions which cause physical pain, such as poor dental care or broken limbs. And you can see this is a picture of an X-ray, and that's a broken elbow that took some time to be picked up, in fact, 2 weeks to be picked up. There's a major overrepresentation in various mental disorders, schizophrenia, depression, and other major mental disorders. And as unfortunately all of you will be aware, there's high levels of abuse of all different types, physical, sexual, etc., experienced by people with intellectual disabilities and often missed. There is also many other health needs, and I'll just go through some of these, such as the underuse and overuse of medications. And this is an old friend of mine who's now passed, and his sister who's now passed, who, when I first saw Peter, he has a number of types of epilepsy. He was on 4 drugs for epilepsy at very high doses. And over the course of a couple of years, we tweaked down the dose so that he was on 2 drugs at about half the dose, and he was much, much happier. And so overuse and poor review of medications, thinking around medications is a major issue in this population. And of course, epilepsy is a significant issue that's often missed, sometimes not picked up, and sometimes not treated properly or managed properly. Infections are common and commonly missed. And there is a range of other things such as health promotion, lifestyle issues, osteoporosis, and people not being able to see and hear properly. It was quite interesting when I first entered this area to see that we think about this in children, and we do test people's hearing, we test their vision to make sure they can see, but in adulthood we tend to forget about it. And often you and I and everybody else, including people with intellectual disability, are trying to adapt to their environment. And we do that by seeing and hearing it well. And if they can't see and hear well, it's very surprising. It's not surprising that they have problems adapting to the world around them. And the final group is gut problems, particularly constipation. And this is actually, I picked an X-ray of somebody who's severely constipated, undescended testicles, and the cause of intellectual disability is often under-investigated. So there's a whole bunch of things that are easily missed. And when you think about this, and I was originally a GP and worked in general practice for 10 years, how is this happening? What are the reasons that this situation exists? And particularly from access to healthcare, why are we missing all these things? And I thought that there's all these barriers and we need to address some of the barriers. And one of the barriers was just getting in to see your GP and getting improved access to see your GP. The other barrier is getting actually a health story from people, a health story that really covers everything. And I can tell you, having practiced as a medical clinician, as a doctor in this space, that often we get incomplete health stories. And I am desperately reliant on you and anybody around you to provide a decent health story to make any judgments around what I think's going on or what I can best help you with improving it. There's also a clear need for people, everybody, people with intellectual disabilities, families, carers, doctors, nurses, allied health professionals, for education and empowerment. And I know that the centre is doing a lot of this work. We know also from listening to healthcare practitioners, such as general practitioners, nurses, what they're really asking for, if you look underneath what they say, is they're actually looking for support so they can do this better. And finally, one of the big problems, which is not news to anybody on this webinar, is we fail to kind of connect up the health system and the disability supports in the person's life in very effective ways. So that led me to develop a process called the Comprehensive Health Assessment Program, which tries to do all those things, to try to minimise those barriers, to try to stop the misdiagnosis and the poor management, and stop people not receiving good preventative health care, and engage and connect the healthcare people, GPs and the practice nurses, to people with intellectual disability better, and also connect with their families. So that was the motivation for doing this, and very much based on what you could see in the systems around people with intellectual disability in the healthcare system and the disability system. So that led to a body of work on what's called as I mentioned, the Comprehensive Health Assessment Program, or CHAP, which is a health check or a health review that is now available and freely available and can be done every year for people with intellectual disability from 0 to whenever of age. It has now got a Medicare and has since 2006 had Medicare support so that the GP is paid to do the process, and has had a range of different testing over the years to demonstrate its effectiveness. So this is if you take out your smartphone or your computer and you put CHAP and health department and you put adult in that search, you will find this page. And I've done it a few times. And there is the CHAP booklet, which is now freely available within Australia. This, as I say, this has been out since 2006 and available. We've had challenges with getting people using it, and we can talk about those things in the questions if we need to. What I was going to do in this presentation is actually walk through a actual CHAP booklet to describe what it does, to reinforce what I actually just said about. Firstly, it gets you the ability to go in and see your doctor and then not to be focusing on a particular problem, but be actually focusing on the whole of you. So it kind of gets a ticket of entry. And then it tries to gather that health story, or tells them about what it's all about. And then it tries to gather a health story in a way that, it's got some limitations in terms of not everybody can complete it, but it tries to gather the health story in a way where a doctor and a practice nurse can actually rapidly look through this information and ask supplementary questions. One of the parts of being any health practitioner, I think, is that you've got to ask good questions, and you can do a better job the better the responses are, the clearer the responses are. And it's really, really important, particularly questions about when this first started, whatever it was, and how it is now, things around the nature of it. So it's really a stimulus to getting people to thinking about the questions about the person's health who's sitting in front of them. And it directs the attention to areas of concern, like epilepsy, like what medications are you taking, sleep, allergies, a whole bunch of areas of concern. And it asks that people with intellectual disabilities, their carers and supporters, gather this information in a way that's accessible to the practice nurse and the doctor, and it's in a format that actually lays it out for them, assists them in this process. So that's the first part of the chat form. And it's changing all the time, as you can imagine. We didn't have COVID-19 vaccination in it a few years ago, but it has now. And it gathers that type of information. And I can't emphasize enough how important that is in the delivery of healthcare. In the middle of it, hopefully in the next slide, yes, it has a list of those problems that I just presented to you that are common. And the reason that it's in the middle is because it actually empowers families, people with intellectual disability, supporters, to question their doctor or practice nurse and say, look, it says this is common and sometimes not picked up. Are you sure that I haven't got this if I'm a person, or that this is not right? So it actually educates the supporters, families, people with intellectual disability as much as it can in this way. And it also says to health staff, these are the things you're likely to miss. And one of the things you really don't want to do as a practitioner is miss things and make mistakes. So it supports them with information exactly when they need it, when they're seeing somebody with an intellectual disability. Then it goes on and it's trying to then help the doctor and the practice nurse go through, work through it and look at various things and provide them some limited information to support them doing an overall review of the person's health and looking for the issues that I've described. So it's got a number of pages that does this. And finally, or almost finally, it tries to actually get them to decide what needs to be done and get the person with intellectual disability and their supporters to actually do those things. Maybe it's going out to have a blood test. Maybe it's going out to have an x-ray. Maybe it's going to see a physio or an exercise physiologist, whatever we agree that needs to be done. So that's the idea, is trying to actually bind those systems together as much as possible. Finally, almost finally, it's got some doctor information in it, because in my experience, where doctors often get nervous when they don't deeply understand something. And if we provide them some information, it makes them more able to think about areas and be more confident in what they do. And so they love actually information. And this is deliberately in doctor speak, I have to say, and nurse speak. And finally, it's actually got the back cover has actually got a chart, because these you can match if you're testing somebody's vision and they don't know their letters, but they can match the various shapes. And this is a matching chart, which was a idea I had at 3 o'clock in the morning that still exists. Okay, so that's what the CHAP is trying to achieve. Now, the CHAP has been used for many years now. In fact, a preceding New South Wales government initially, I think, used it in the early 2000s, and other governments licensed it and used it for over many years. And then the NDIS and the federal government are now using it and make it freely available. And people have, because it's it is almost uniquely an intervention in the health space, that actually there is very, very, very strong scientific evidence for its use. This is quite hard to achieve, but it is the case, and people are now actually trying to have various strategies to try to help various groups deliver the annual health assessment. And this is one strategy that I came across, which is a beautiful bit of work done in Sydney in the Primary Health Network in central and eastern Sydney. You can see it in the top left-hand corner of the screen on that slide. And this is a checklist for support workers in houses to prepare to go and having a health assessment. And it walks them through a month of preparation to try to get a really good health assessment done. And I would recommend this to anybody, actually. I think it's actually really good, because it's not an easy process. Getting it all right and getting the right things to happen. So that's the CHAP. and I'm more than happy to answer any questions you might have around this. I also think in life generally and in trying to get access to services, what is really helpful for people with intellectual disabilities and their families and supporters is to actually understand, be in the shoes of a GP. Now, it's not quite a time since I've done general practice, but I did it for about 10 years. So I definitely have a feel for it. And I did it in both rural and urban, in city places, in Victoria and Queensland, in Victoria and in New Zealand. And I think what is generally not appreciated, like as we look at the whole GP system, what we have in Australia, and we know from research, it's actually one of the best in the world, even despite all our problems. In fact, it was nominated as best in the world recently. And the reason for this, it actually is much better than other forms of systems at producing better health outcomes, access and equity, better access and ability to spread across the population. There is, however, significant concerns about attracting people to work as general practitioners. When I trained many, many years ago in Tasmania, well over 50% of people who started training as a doctor wanted to become a GP. This is now down to about 14%. So we've got some major workforce issues, which the government has been for years trying to address. Working as a GP is probably the most difficult job I've ever had. It's incredibly demanding, and you have a friend, and the friend who is also an enemy, and time is often your enemy because it's very hard to deliver in the type of time frame, healthcare in the time frames, in the way that general practice is structured. It's quite challenging to do that and do that well. However, time is also your friend, because what you do as a GP is hopefully you see the same person every so often, and you get to know them and they get to know you. And that's really, really, really handy, and can't be underestimated. I won't give it as an example, but it really does help. And we know that, in fact, if you've got a relationship with your GP, they're actually more likely to go further for you and push harder and push harder and push harder. So building that relationship is really important. I think there's various strategies also that go with working in general practice. For example, health assessments take a lot of time for GPs, and I say to people, never do them on a Monday or Friday, because they are the busiest days in general practice. And negotiate with the practice about the timing of such things, if you can. Practice managers, receptionists, or nurses. Nurses in practices can have an extraordinary role in doing this type of work. And I've had the pleasure of being in that situation a few times. I'd also point out that, in fact, the federal government, who I work for as a senior medical advisor, are trying to nudge the system on over time to more block funding in general practices, so health resources can be directed to those who need them most. In the current system, which is fee for service, and a GP is a private business, remember, is not totally fit for purpose, and we need the ability to get extra attention to people that actually need it. And the government is moving in this direction, and in the long-term planning to move towards multidisciplinary team models. So I think there's some movement and some good things happening in this. Okay, so if I think about you and trying to negotiate, I think it's really important to think about negotiating with your practice, and how you can best work with them and understand their context, and they can best serve you, if you could possibly do that. I realise this is not easy. I think it's worth always preparing, including having questions. And I know some doctors don't like this, but even I forget questions, and I'm a doctor. I go to my GP. And also be prepared to go back if you can. And always ask, what's next and why, and what happens if this doesn't work? What do we do then? Are good questions to ask. They may not be easy to answer, but they're good questions to ask. There's also some other increasing things happening in general practice. There's a thing called My Medicare, where half of Australian practices are signed up to this. And the advantage of registering with your practice in the My Medicare is that you get some extra funding for long teleconference consultations at the moment, but it's also going to be a mechanism for the government to redirect health resources to people with intellectual disabilities, others targeting those groups. They've done this particularly in the care of elderly people under the My Medicare. And I would recommend that you see if your practice is part of My Medicare and register with them, which really formalises the link between you and that general practice and general practitioner. There's also been, you can have a health assessment done, which I would say you should be doing on an annual basis. But if people have got chronic conditions, then there's a further management plan that can be done and is paid for by the government. I think the other purpose of GPs is to hold the system to account and make sure that people are getting good care. Okay. And I'll finish there and hand you back to Amanda.
Rebecca?
Thanks, Amanda. So I was just going to talk as a parent today, and I'll talk about some of the experiences my son, Ryan, and I have had in the medical system. A few of the things that we've learnt over the years. But just to start with, this is Ryan. So Ryan's 15 years old last week. We live in regional Tasmania, which sort of has certain impacts on how we live our lives and where his medical care comes from. And I'm a single mum, and he has his two sisters live with us as well. So Ryan's in grade 8 and he goes to a mainstream school. He's not, well, I say he's not verbal, but he's a very rich communicator, very occasionally spoken words, but lots of, you're very rarely in any doubt as to what Ryan thinks about things. Absolute lover of hot chips and iPads, but he's also very medically complex. So you can see on the slide he has Down syndrome, but he also has type 1 diabetes, was born with a cleft palate and heart defects, had leukemia when he was 1, has a lot of different chronic ear conditions and vision conditions, and is deaf. And a big part of the story for us, and what I'll talk about a lot, is complex trauma and anxiety. So, and how we manage that. Just to start with the past, wasn't he cute? So when he was born, his medical care, there was lots of intervention. So he was born, he was a postnatal diagnosis, and he was on the ward for about 4 weeks, where we went through a whole pile of blood tests. He had feeding issues, particularly with his cleft palate. He went into heart failure. So he sort of arrived in this flurry of medical intervention. When he was a year old, he then developed leukemia. And being in regional Tasmania, we had to move to Melbourne to get chemotherapy for his chemo there. Over the next few years, we're very busy. He had to have his tonsils and adenoids out. He had 2 repairs for his cleft palate. He had eye surgeries. He had open heart surgery when he was 4. So a really big, busy period of lots of different surgical interventions and appointments. At around 7, he had a developmental regression, which we think is probably due to the trauma that he'd been through. So before 7, he was quite verbal, hard to understand, but he communicated, was very friendly, had several hundred signs that he would use. At 7, he just shut down over the course of a couple of months. We found out he'd gone deaf at the same time, so he did develop a severe to profound hearing loss in both his ears. But he was a very different person after 7 than he was before. From 7 onwards, we've had this long period of escalating chronic ear infections. He has had numerous significant surgeries and lots of hospitalizations over those period. And then in grade 5, he developed type 1 diabetes. So he's had a lot to go through. In terms of our ongoing health concerns, our life is still very tied up with the medical system. Type 1 diabetes is lifelong, it's life-threatening, and it does require very careful and constant management. His chronic ear conditions cause us a lot of grief. At the moment, things stay pretty stable if they can clean his ears out every 3 months, but he can't tolerate that being done awake, so that requires a general anaesthetic, and that falls apart really quickly when they lose paperwork and we don't get back in the system. So they tend to escalate if they don't get cleaned out at that 3 months. He has a really high risk of these sort of escalating infections and sort of acute medical conditions. Sometimes they're from his ears not being well managed. In other cases, so the pain that he gets from his ears, for example, he bangs his head to help him with that pain. That then has led to things like a swollen, painful arm. He gets chronic head abscesses from that. So he's kind of got things that develop because of the other conditions he's got. So a huge part of his story has been around trauma. And that's the big regression he had at 7, and understanding that he has gone through a significant amount of trauma, and he is, as a result of that, demand avoidant. Any kind of medical procedure or being in a medical setting is a massive trauma trigger for him. So we don't have to do something to him for him to be traumatized. We just have to go to the doctor and sit in the office. I think people get confused that this isn't a choice. So that kind of demand avoidance isn't a choice that he's making. He's not being difficult. You literally can't push him through it, or encouragement or discipline through there. Things like, and this took me a while to get my head around, things like, do you want to drink? So just asking a question and expecting an answer is a demand. And even praise is a demand. So if you say, oh, great work, Ryan, that can actually shut him down, because that's a demand. So in terms of this, what's really important for us is for him to feel safe, and that's around relationships and routines and being listened to, understanding and respecting his boundaries and consent, and giving him choices. I'm going to put a caveat here, because every tip I give you about how we navigate this health system, I think what's really important is to recognize that you are navigating a broken system. It's too much to expect you to fix all the holes by just having a few tips that work. So the system that we're living in is very broken. There's a really poor level of understanding of intellectual disability and diverse communication styles, and particularly the complex medical conditions. So we have really limited access to reasonable adjustments. The medical model of disability is rife in the medical system, and it's outdated and it's dangerous in terms of the way that people with intellectual disability are seen. I find often there's a lack of acknowledgement of human rights in healthcare settings. Diagnostic overshadowing is a huge issue for most people, particularly with kids with Down syndrome. We hear it a lot. Poor coordination and communication between different parts of the health system. And this is really hard for regional families in particular. So where I am, we work across 3 different health systems because we have to go, Launceston, Hobart, Melbourne. And then on top of that, you've got GPs and things. So trying to get those different specialties and the different systems to talk to each other is difficult. I think the other thing that we notice a lot is that there's a real lack of respect for voices of people with disability and also their carers and support people. Acknowledging the role that carers and support people play in facilitating that care, and as the experts in the person they support, but also then respecting the rights of people with intellectual disabilities to make decisions around their own care. So the caveat I say is that system failures aren't your fault. You can work in a broken system, but honestly, the pressure on families to do everything right to avoid poor outcomes is huge. It's unrealistic and it's totally unfair. I had a GP say to me actually on Sunday, he just looked at me and said, it shouldn't be your job to come up with this plan. One of these people should be doing it. And I was like, yeah, it shouldn't. But the reality is if I don't do it, who's going to do it? Having said that, some of the things that work for us, so a lot of our adjustments are really around managing trauma and minimizing trauma and making the system work for us. Low demand. Friendly people, Ryan is quite scared of friendly people, and that's a consequence of a long history of people coming in, lovely doctors and nurses, super friendly, and trying to engage with him. Over time, he became quite fearful of those people. So I actually ask staff not to be overly friendly, not to place those sorts of demands on him. And I say, just come in, be matter of fact, tell him what you got to do. Don't try and be his friend. It's so confusing and it really adds to his trauma that people are, if they come in and they're friendly, he's pretty much on guard straight away. I tell them, get in, do it, get out, essentially. And it can be really confronting. I've had staff push back on that. Be really clear on what's a have to and what's a can we. So often people say, Ryan, can I take your blood pressure? Ryan, can I do this? And when he indicates with his body that, no, I don't want you to, then they've backed themselves into a corner and they do it anyway because they've decided it's a have to. And so I say to them, it's really important that his choice is respected. There are things we have to do. He has to have insulin or he dies. So that's not a choice. I don't say, Ryan, can I give you insulin? I say, Ryan, insulin. That's what we're doing now. But do I need to do his blood pressure right now? Well, probably not. So, Ryan, can I take your blood pressure? If he says no, and he doesn't have to say it verbally, but if he indicates it with his body in any way, then no means no. And so we're building his sense of safety by when it's a choice, we respect his choice. And over time, his tolerance for some of those choices has actually increased because of that. So I just make sure that when we talk in the hospital and we ask, I get them to make it clear, if you use the words, can I, then he can say no. And that needs to be respected. Acknowledging his feelings. So I had a lot of people kind of, oh, don't worry, Ryan, it's not going to hurt you. Don't worry, they're just going to do this. And actually, that's really difficult for him. So just having to sort of have this acknowledgement of feelings, like we know you don't want to do it. It's okay to like that. We know that you are angry. So I think one of the things when you're nonverbal is not being heard. And even if we have to do it anyway, but actually just acknowledging those feelings. Predictability works really well for us. So we use a lot of keywords and visual cues and routines. Everything we do has a beginning, a middle, and an end, and we repeat it exactly the same each time we do it so that we can build his comfort with the procedure or the event. And an example of that was when he got type 1 diabetes and we had to start giving insulin. I was quite concerned how difficult this would be, but we created straight away a simple routine. Hold the pen up, insulin Ryan, inject it in a certain area he was comfortable with, count to 10, and then say and sign finished. And within a day, he was totally accepting of that procedure because he knew exactly what was going to happen. He doesn't like it. He doesn't like being injected with insulin, but he tolerates it because he's not scared about what's going to happen. He knows exactly what's going to happen. Lately, we've had some real success with safe access to safe, quiet spaces in hospitals, and they've been amazing. So instead of sort of waiting out with everyone else, we put in an office somewhere and sit quietly by ourselves, away from that medical feel, and that's really reduced his anxiety going into procedures. Translation rather than comforting. So I think we disempower people all the time by doing that comforting. And so instead of me saying, it's okay, Ryan, they're not going to hurt you, that's a lie. So being in that room is hurtful to him. He has trauma. It is a trigger to be there. It is painful for him to be there. Instead of that, I say, Ryan doesn't want you here. Ryan doesn't like it when you do that to him. He's scared you're going to hurt him. That can be really confronting. And I say to medical professionals, I'm not telling you to go and I'm not telling you not to do it. I'm just going to translate for Ryan. And then I'll say, Ryan, I know you don't want them here, sweetheart, but we need to do it anyway. And he's actually, that's been really powerful in terms of him feeling heard. And I've noticed that his stress in these things actually decreases. It's like so much of his behavior was about not being heard in the space rather than accepting that it had to happen. Minimizing traumatic experiences. So I am often put under pressure to allow them to do things, suction his ears out awake. I will not allow anyone to do those sorts of things in a clinic. This idea that we might just see if he can tolerate it. It's just without sedation, it's just caused so much grief in the past that I really go out of my way now to just minimize those and push back. Um, so as part of that, we use sedation pretty much for anything these days that's invasive or if it's a difficult to cope with procedure. So that can be very hard to access sedation, particularly in regional areas. We don't get a lot of choices with sedation options. So essentially here I can either take him to the emergency department and we can wait for a resus bay, which is, if it's because I need them to look in his ears, that can be a long wait because it's not an emergency, but that's the only place they can really look at him, or it requires a full general anaesthetic. So he is lined up for general anaesthetics every 3 months, and you would think they would be a great opportunity to do other procedures while he's underneath, but I have yet to be able to arrange that at our local hospital to actually get 2 or more procedures done while he's under. Blood's pretty much the only exception. I wish I knew about pre-meds. I was very dismissive of using pre-meds when he was little, and if there's something I could take back, that's one thing I would definitely take back. I would definitely use a pre-med going forward. We use midazolam clonidine, and it just makes for such a smoother, less traumatic recovery for him. Some of the other tips I give you, always get a copy of the notes. You are the facilitator of their care, essentially. No one else is going to do it. You won't necessarily be recognised as a facilitator, and it's amazing how often you get pushback for asking for notes. So ideally, when you ask for them, someone will give you a copy of them. Less ideally, and this has happened a couple of times to me where I was told, no, your GP needs to ask for the notes. You usually just wait till they leave the room and grab the patient folder and take some photos. It's not a bad trip. Know your terminology. This one, unfortunately, it works and it's important, and it's not fair that you should have to know the terminology, but if you can speak their language and show that you know what you're looking at, you'll be taken more seriously. So if you go in and say, oh, I'm worried about my child's breathing, they'll often be a bit dismissive. If you go in and describe the specific symptoms that have got you concerned, there's tracheal tug, there's intercostal recession, suddenly they take you more seriously. Other parents are a really great way to learn these words and to understand what they mean, and they'll often put videos up showing these things. If you can get into a parent group particularly, so you can learn about the conditions and you can learn the language and the sorts of questions you need to ask, it's really valuable. Some other tips, never be scared to question and push back on recommendations and decisions. I think sometimes people perceive doctors as some all-knowing gods. They're not. You're allowed to ask questions. They need to explain to you why they want to do things, not just tell you what they want to do. And don't feel shy to actually question those. Sometimes what seems obvious to a doctor or a nurse is actually not at all obvious and not even in the best interests of your person. You know them well. If that's not going to work, then tell them it's not going to work. Challenge their assumptions about your person and their disability. So you're allowed to say, when they say, oh, that's just, that's common for Down syndrome, that's normal for Down syndrome. No, it's not. So feel free to actually say that straight to their face. It's not normal for Down syndrome. What would you do if they didn't have Down syndrome? If it's not clear, then ask. There's no such thing as a stupid question. Usually that just means they didn't explain their answer very well. It's not your question. Wait and see, I think, are the most dangerous words that I've ever heard in a doctor's office, and you hear them really often. It's a really strong preference amongst medical professionals, some medical professionals. I think often, particularly for junior doctors, they feel scared of making decisions and they can kind of get stuck in this, let's wait and see. But wait and see is laziness and it's not care. For people like Ryan, he's already very sick by the time we notice. So you saw the slide of Nick's with the poor person who had a broken arm for 2 weeks and didn't know it. By the time you figure out there's pain, what might be the cause? You get the x-ray done. It can be a long time between when they first show some sort of symptom to when they're diagnosed. So waiting to see if things change is only going to make that worse and really allows it to escalate. Diagnostic overshadowing is a huge issue. So a lot of these decisions that are made based on low expectations of people with intellectual disability. Normal for Down syndrome is never ever a reason not to investigate or treat a medical condition. It might be quite common for people with Down syndrome to have heart conditions, for example, but that doesn't mean we don't treat them. So that means we look for them because we know that they're likely to be there, but we still treat them. Things like they're not able to cope with the treatment, or, some of these sort of better to let nature take its course, they're all about medical bias. And you really need to constantly push back and say, well, what would you do if they didn't have Down syndrome? Let's give them that quality of care. Be assertive but not aggressive. So you do need to stay calm, and that's really hard sometimes. Be professional, state your position and expectations, and just try and avoid getting into circular arguments. I'm always the person that keeps going up. So, you can't always resolve things with the first doctor you talk to or nurse. You do need to keep a collaborative mindset. So try and think of yourself as part of a team. I do kick people off the team, but try and create a team around you that is respectful. A high emotion and confrontational styles, if you're doing advocacy with your person and you become really confrontational, it tends to just make everyone around you very defensive, and they band together against you as the threat rather than being open to alternative ideas. So I guess the last thing is around what do you do when it goes wrong? So if you're on the ward or you're in the emergency departments, you start by just escalating your concerns. And I find often junior doctors are intimidated by senior staff, and they'll often do nothing to avoid getting into trouble for doing the wrong thing. So you need to go up. Often, if no one's doing anything, go up. Ask for a senior consultant. Nursing unit managers, nurses are great patient advocates in a lot of cases, and I've seen them go head to head with doctors and win. If you have to, don't be scared to use the hospital escalation process. So MET calls or RINES or whatever it is in your state, they're there for you and you should use them. When things go wrong outside the hospital, so as outpatients, hospital complaint procedures are terrible. They are not designed to resolve any kind of urgent issues. They are 42 days to reply, and what you get back is a letter saying, we're really sorry you are upset. They don't at all help you move that care forward. The health ombudsman's no better because you've got to go through that plus some. Second opinions I find are tricky. It can be really good if you're at a GP, for example, a second opinion can be good. If you're talking to specialists and things, particularly in a regional area, medical professionals tend to close ranks and they don't tend to want to upset their colleagues. So it can be really hard to get a truly independent second opinion around things. Outside the hospital system, so as an outpatient, the best thing that I've found is actually complain straight to health ministers. So I don't complain to a hospital anymore. I complain to the health minister. I don't do it over small things. I only do it over really big things. But when you do that, you need to just be very clear about what the issue is. You give a really non-emotive account of everything that happened that led up to that issue. So the phone calls that happened, the conversations, the names, the dates, whatever it was that led into that problem. Explain very clearly what happens if they don't fix it. So, if this doesn't happen, then that's going to be the outcome. And then state the solution you want implemented and be very specific about the actions they need to do right now, because what you don't want is just a letter telling you how sorry they are. I used exactly this approach after Ryan got diabetes. He got lost off the system for an ear clean out, and we had 10 weeks of escalating infections. And I struck the worst admissions nurse ever, who decided to just make our life impossible. And in the end, having rung about 20 different phone calls and different attempts to get back in the system, I was told it was going to be another, month and a half or something for him to get in. And I complained to the minister and got a phone call apologising that they could only get me in next week. So it resolves issues very quickly if you can take it up to that level. And that's me, and I'm going to pass to Brooke.
Good afternoon. My name is Brooke and I'm a policy officer at Inclusion Australia. I'll be talking about It's Doctor Time. I would like to start by acknowledging the Whadjuk Noongar people as the traditional custodians of the land that I am speaking from today. We acknowledge the traditional custodians on the land where each of you are living on and working on. We pay our respects to any First Nations people joining us today. I also want to recognise self-advocates who have worked very hard over the years for equality and human rights for all. Inclusion Australia is a national disability representative organisation for people with an intellectual disability and their families. We bring people together through our members to support and advocate for people with an intellectual disability. I'm going to talk to you about a project we did called It's Doctor Time. It's Doctor Time is all about yearly health checks. So, what is a yearly health check? So, doctors sometimes call it an annual health assessment. It is a big appointment with the GP. GP means your regular doctor. Yearly health checks are designed to help find preventable health issues and conditions for people with an intellectual disability. They are Medicare supported. This means Medicare will pay for most or sometimes all of the appointment costs. Tools like the CHAP, which stands for the Comprehensive Health Assessment Program, are often used in the yearly health check. Most importantly, yearly health checks are proven to improve health outcomes for people with an intellectual disability. But there's a problem. Not enough people have been visiting their GP for a yearly health check. The government told us that only 7% of people with intellectual disability on the NDIS and disability support pension have been having the yearly health check. So the Department of Health and Aged Care asked Inclusion Australia to help increase the number of people who are having a yearly health check. In 2024, we launched a national campaign called It's Doctor Time. We co-designed easy to understand resources for different audiences. These include people with an intellectual disability, their families and supporters, general practice staff, and service providers. The easy to understand resources include easy to read fact sheets, conversation cards, social story templates, and videos. You can find the resources on our website. I will show you an example of the conversation cards today. We made these conversation cards to help people with an intellectual disability and their supporters to learn more about yearly health checks and what happens during the appointment. There are three different types of cards: scenario cards, question cards, and true and false cards. Let's practice using the true and false conversation cards now. You should think about the fact and ask yourself, is it true or is it false? True means it's right and false means it's wrong. There's going to be a poll put up. So I should only have a yearly health check if I feel sick. Is that true or false? And he responded, the answer is false. So well done who got that. It's important to have a yearly health check once a year. If you are not feeling sick, a yearly health check can help find sicknesses early. We suggest that people pick a special time each year as a reminder to book their yearly health check. This way you are less likely to forget. It might be your birthday, or some Valentine's Day, or the AFL Grand Final. Before I finish my presentation, I wanted to share some of my own tips with everyone so we can improve our health. So I think it's important that we all eat more fruits and vegetables. I love cooking and trying new foods. My favourite fruit is mango, and my favourite vegetable are broccoli and pumpkin. We should all drink lots of water to stay hydrated. I always have a drink near me when I am working. You can always bring someone you trust to the doctor for support. This can be helpful if you are feeling nervous or unsure. It is important that you ask the doctor to re-explain anything that you don't understand. It's important you speak up and tell them you don't understand. They can explain differently and draw photos. So, what happens next? Remember to book your yearly health check if you haven't already. Help other people stay healthy by telling them about its doctor time. You can visit our website for more information. If you can scan the QR code, it will take you to our website. Thank you. Back to you, Amanda.
Thank you to all of our speakers for today, for your presentation today. If you have any questions, please put the questions in the Q&A box. You can find the Q&A box if you click on the three dots that says more at the bottom right of your screen. Brooke or Nick, has the number of people getting health checks each year improved since it's doctor time?
I haven't looked at the statistics at the moment, but I can get back to you on that one.
Unfortunately, I don't think we can easily tell is the problem with this. The when there was a way to tell, but it's many years ago, and it's quite difficult to tell because we don't have anything in the Medicare system that identifies that the person that had a health check had an intellectual disability, and unless we can do that, it's quite a complex piece of research to try to work that out, and not easily possible. We have indications to get this very accurately, I'm afraid. I wish I could answer yes to that question, but I can't.
So Rebecca has a question. What would you suggest people look for when they are trying to find a doctor that will do a good job for people with intellectual disability? I don't know who I'm supposed to ask it to. There's no names. It's just a general question.
I'm happy to answer. Maybe Brooke would like to answer as well. Did you want to answer first, Brooke, and then I'll answer?
So obviously I also have Down syndrome myself as well. So we got recommendation of a doctor who works very closely to people with Down syndrome. So that's how we got in the network of having a really good GP.
Yeah, I expect like I find it's a personality thing. So like we saw a doctor on the weekend who was a new doctor to us, and he had a wonderful the way that he treated Ryan, the way he spoke about him, he was very respectful, and I think that to me is a real sign. So you can you get a real sense of whether they see your person as a person. And he was very attentive and he listened to everything I said. And I think that's the thing is you really want people who are respectful. And he was very thorough too. But yeah, I find it's a personality thing as much as anything.
And
Can
I
I
feel
make a comment on?
like,
Yeah.
Yeah. Okay, so I get asked this quite a bit. In fact, when I was thinking about what questions might be asked, this was the question I thought, because it is very difficult. But I totally, if you can find somebody that is, as Rebecca suggests, respectful and knows, the area, and that is the key criteria. One of the interesting things that the way that, because it's very difficult for a doctor to recommend other doctors, there's some ethical issues around this. But if you broadly look, I would say doctors in general practice, there's general practitioners who train other general practitioners in practices in Launceston and other places as well. And my experience as somebody who's trained as a GP is that the doctors that do the training are often excellent. And often the trainees that they've got will be more respectful because they're junior. But so whenever I've been asked what practices I would recommend, it's not only those practices, but where there's general practices with GPs that train other doctors, they're usually really, really good. In my experience.
Rebecca, I also feel like as well, if they actually are trained in intellectual disability and disability. So, how do I say it? Like I don't want to go to the doctor and get treated like a baby and going, oh, so what's wrong with you? Kind of sense. I want to speak as an adult form and still have my support person with me, but speaking to me and not my support person. And knowing that if I need help, then they can go direct and explain things to my support person and not go direct to them. But I feel like they need to be trained in all disability areas and intellectual disability, because if they don't know that, and how can they work with somebody who has a disability and an intellectual disability?
Yeah, I agree, Brooke. I find with Ryan, I find it interesting because he's not verbal and he likes to on his iPad he likes to watch nursery rhymes and things. I always tell the good doctors and the people who get him as they talk to him as the teenager that he is. They don't talk to him like he's a small child. Like they just, hey mate, how you going? They're very respectful and they treat him like a teenager. And I find that's a real like it really signals someone who kind of gets it. I think that level of respect, respectful behavior.
Yeah.
Okay, we have a question for Nick. Nick, what can families do to establish a good relationship with their doctor?
I mean, the first thing is selecting, which we've talked about. I always think that you kind of, for me, and you're somebody who you kind of share something with. There's a kind of a connection. That's got to be the starting point, I think. In terms of establishing a relationship, I think it's kind of all the things that we said is to understand their context and to um, negotiate, as Rebecca was saying, be um, assertive but not confrontational. There's a balance there, and being very clear about what you want. But from my point of view, also understanding they've got some limitations around what they can actually do, um, and respecting that. So for some people, actually, they negotiate with the practice about where, with the actual practice, look, I need this situation, I want to do this. I realise you've got, this is difficult for you. Maybe we could do this. So I think it's kind of, it also can be at another level, a negotiation beyond the personal interaction, as well. I'm probably not the best person to answer this question. I think Rebecca's probably the best person to answer this question, or Brooke. Um, people do like being, people hate being asked questions, but also it kind of asserts that you're in the game and you're thinking about it. And I think that's actually quite useful. Yeah, sorry, Rebecca, I interrupted.
Yeah, no, I was going to say, I always think it's a team, and it's sort of sending that I'm the project manager. So, but
Mm,
really, I think that's part of it is you've got to pull people together, but you've got to talk to them, be grateful. So be really grateful at the things that they do that helps. So the same way you would manage any team, you sort of tell them what they did well, you reinforce that you really appreciated certain things. It's the same vibe, but at the same time,
mm,
you tell them when something needs to change calmly,
mm,
assertively, but not aggressively. And I think it's been the same at school. All sorts of places in our life is about building really respectful, collaborative teams. And I think you've got to see all the medical people you deal with as part of your team. So, they're on Team Ryan, and all of them really love Ryan. They want the best for him. So actually, all of us are in
mm.
his best interests. And if we can kind of keep that team mindset, that helps a lot.
And I reckon as well with having the relationship as well with your GP as well is having them for a long time. So I've been with
Mm,
mine now for 17 years.
mm,
And that connection goes stronger. So they see the progress of you going up or going back downwards. So like I've recently seen my doctor and I'm kind of like in the backward station at the moment. And they're trying to help me progress to move forward a bit more
mm,
and get that bigger step forward. And so
mm,
having that connection with them, knowing that you trust them, and that's a big word to trust and respect. Sometimes I misunderstand a few things. So like when you have a telehealth on the phone and then you're going in afterwards to just check up on a few things, they misinterpret a few things that you said on the phone. So I feel that's a bit frustrating, that part of the side. But I do like the follow up when you do go in and see after I tell you your health. And like, I rather for myself, for who had doubts and know myself, I rather go in to my doctor and actually speak to my doctor and not do a telehealth because I feel like you can misinterpret things. They might forget to put that on your notes. And so I feel like being there verbal, you can actually write it in your phone, you can write it in a notepad, you've got it all there in front of you. Instead, like, oh, I need to give you a script for this, I need to give you an X-ray form. How can you give it over the phone? You can't. So it's easy to just be in face to face to, just to build that relationship with your doctor to make it stronger and fonder.
All
yeah.
right. Thank you. I've just got a question for everyone on the panel. And this one, to me, is a really good question. What should happen for people with intellectual disability who don't have families who can help them with health? How can support workers provide support or be involved in appointments?
I feel like if like as a person with Down syndrome again, if I want a support person to be in the room, I'll ask that question. But I'd rather have a nurse who knows my history to be in that room, and in case I don't understand something, they can help with it, and then I can always go back to the nurse and actually not disturb the doctor next time I need some advice, and not go and making sure I feel safe in that network and in that center. They're not going, you know what I kind of mean, and not having a support worker, because I don't feel like support workers will keep it confidential. I feel other support workers might say something to another, like, to another participant, or maybe, or saying, oh yeah, I've got the same kind of thing with another participant going through the same thing. And I don't feel that's a safe environment to have support workers actually knowing your health history and knowing if something's actually going seriously wrong with you. So I know that's a big question, and I know some people who will need support workers, but my perspective for myself, I don't think that's the right thing to have.
Yeah, I think it's very hard when you don't have family. So I know as a parent that I don't think there's anything that scares me more than that moment when I'm not the one that can take Ryan to the doctor and keep track of everything. I think if I wasn't there, so if he, and there will be a day when I won't be there and he will need to have support workers do this. I think the communication amongst the team, so making sure that the support team actually keeps on top of what happened at the appointment, what's the follow-up, what are the next things that have to do. So all of that has to be really clearly documented and passed on so that everyone who's managing that person's care is aware and that they're following up. I think trying to make sure that they have consistency, so seeing the same GP, so that someone knows this person's long history and is keeping the eye. And I think your idea of the practice nurse, Brooke, is a great one. So if there's a good practice nurse there, that even if it's a different support worker that comes into each appointment, which it might be for shifts, that you have that consistency, but also the communication's been good enough that whoever's on shift today knows what the questions are, knows what the follow-up is documenting what comes out of that. So I think it's got to be a real coordinated effort there. I think for the support workers themselves, though, that making sure that the person has a voice themselves. So it's not just a consultation between the support worker and the doctor. It is a consultation that is between the person and the doctor, and the support worker's there to assist with that. Now, for someone like Ryan, who's not verbal, obviously they would be leading that conversation, but their job is still to translate for Ryan. It's still to, what is his body saying? No, he doesn't want you to do that here. No, he doesn't. He needs sedation for this. Their job is to make sure that his voice is being heard through that. So to know what his preferences are, to know what works for him, what adjustments don't work for him, and then to advocate for those. So I think it's a really important role as a support worker. I think we're all terrified of it as parents particularly, but it'll happen one day that it has to be the case. Nick, sorry, I think you had lots of...
Oh, no. Well, I mean, Brooke and Rebecca have basically covered many of the things that I was... But if I'm thinking about a support worker, so the situation where a support worker has to go on, this question is maybe from a support worker. The point you do make is it's absolutely essential that you know the person and are trusted by the person that you're supporting, and you know them with, I think, a high degree of intimacy, particularly if they are not easily able to communicate to the doctor. It's absolutely crucial, and that you have this detailed knowledge. And Brooke, I'd say if somebody can't talk about their health or their health record, it's absolutely essential that the health support worker is able to do that, and also has the nuance and understanding to do what you just said, Rebecca, to communicate. This actually, because it's not behavioural communication of speaking with behavioural response is not necessarily obvious to people that don't know the person. And they've got to be able to step in and say, well, actually, this is what I think. And that's when I've found it most helpful, that it's the informed, really nuanced understanding from the support worker about this person, but also able to back off and pay respects. So in the situation where people with intellectual disability were seeing me that didn't have excellent verbal communication. Or even, I would initially always make sure that it didn't matter that the first person that was important in the room was the person with intellectual disability, and then so that they knew that I was there for them, not for the support worker, and that was where you start. So, that's my thoughts about the one. It's a really important question, and makes a huge difference if you do it well as a support worker. I'll stop, Amanda, because we might be running out of time.
Just one last question for all the speakers, as we are running out of time. What is the one message you want people watching here today to take away from the presentation? Rebecca, may I start with you, and may we please let Nick finish? Is that okay?
Oh, that's hard. I was hoping I'd get two people's worth of other ideas to think about.
You don't need them, Rebecca.
I guess what's the one thing? I think we've talked about it just as that the person is central, and it's actually what works for them. And regardless of whether that person communicates through speech or not, it's actually thinking about what fits them. So what are the things that reduce their stress in it? What are the types of communication that work for them? So I think the more we can put that person at the middle of it all, and actually adapt the way we do things to suit that person. So it's not just about intellectual disability, it's actually about the human. I think that's the big thing, is to think about what works for that person. Brooke?
Oh, that's right. Nick's finishing. Sorry, I forgot.
Yes,
From in the middle. So I feel like that everyone, if you haven't had your yearly health check, I feel like you should go for a yearly health check, and to make sure that you are staying healthy and actually make your own tips and understand how to stay healthy and to just be active again to stay healthy. Go with you, Nick.
Yeah, I mean, I was going to say that one, Brooke, you've stolen it. But I was, I mean, essential to all of this thing is the broad process of really good communication and people and respect. That's what are the key issues in all of this stuff. Good advocacy comes from communication and respect. Good treatment by doctors comes from communication and respect and understanding. And that's absolutely central, the communication issue. That's what I would say. And have a health check every year.
We will have to close there. Thank you to all the speakers and the audience for being part of this important conversation. Thank you. I hope you enjoyed today's webinar.